The broadcast is now starting. All attendees are in listen-only mode.
Good morning, good evening, and welcome to the webinar on the pharmacological treatments for osteoporosis. My name is Masaki Fujita, and I'm the Science Project Coordinator at the International Osteoporosis Foundation in Switzerland. I'm also the Capture the Fracture Program Coordinator. It is my great pleasure to run this webinar with our speaker, Professor Nicholas Harvey. Professor Harvey is Professor of Rheumatology and Clinical Epidemiology at the MRC Life Course Epidemiology Unit at the University of Southampton in UK. He is also the Vice Chair of the International Osteoporosis Foundation Committee of Scientific Advisors. Now, before I begin, I'd like to inform you that attendees are muted. If you have any questions, please feel free to type your questions into the question box of the panel. Questions will be collected and we will do our best to voice them towards the end of the webinar. Now, Professor Harvey, when you're ready, please begin.
Thank you very much, Masaki, and it's an enormous pleasure to be here to give this webinar on behalf of Capture the Fracture for the International Osteoporosis Foundation. And I thought what I would do in covering the sort of pharmacological approach to osteoporosis is to set this in the context of the burden of disease and think about the absolute need for assessment and treatment in the context of the fact that there are major gaps in these areas. And then looking at how we can close these gaps, addressing both primary and secondary prevention, and focusing in a very pragmatic clinical way on the treatments that are available and the approaches we can take to reduce fracture risk. So it's no surprise to this audience, I'm sure, that osteoporosis has a huge impact both in Europe and across the world. And we know that for a 50-year-old woman, in many countries, the remaining lifetime risk of a fragility fracture is around 1 in 2, so 50%, and for men it's around 1 in 5. And osteoporotic fractures don't just have immediate problems in terms of pain, disability, but also can have a long-term effect on factors such as mobility, independence, but also upon relative survival, with major osteoporotic fractures having an impact even up to 20% or so over a number of years compared with non-fracture peers. And this costs a huge amount of money, so around 39 billion euros a year across the EU. And so osteoporosis has a huge impact and huge relevance for individuals, for healthcare systems and for societies as a whole, and is clearly a huge global burden. There's also a major issue in that the number of fractures is increasing worldwide, and that's because populations are aging, regardless of any changes in age and sex-adjusted incidence. Because population structures are aging, particularly in the transitioning populations, the developing world, we're going to see at least doublings of those at high fracture probability, and this is worked out using FRAX and using the probability conferred by having had a fracture in the past as an indicator of high fracture risk. And if we look at the number of individuals worldwide in 2010 who are above this threshold, there's about 158 million, and that's going to double by 2040, just based on the population projections that we can measure currently. And those increases are going to be most marked, as you can see here, showing the relative increase 2040 versus 2010 in low middle income countries such as across Africa, Latin America and Asia. And so this is a huge global burden, not just for Western populations, but also showing major increases across lower middle income countries' transitioning populations. So I tried every once in a while to put in some key learning points to draw out some important messages. And of course, osteoporosis is common worldwide is pretty obvious. But populations are aging worldwide, particularly quickly in transitioning populations, and so number of osteoporotic fractures will increase. And it's vitally important that healthcare systems and public health policy must address this enormous future burden of disease. And it's in that context that the the documented gaps in prevention and treatment are so critically important and so critically worrying. And these have been documented in detail in the 2016 World Osteoporosis Day report from the International Osteoporosis Foundation, which I co-authored with Eugene McCloskey and Paul Mitchell and others. And here we documented a series of gaps in the assessment, prevention, treatment, public awareness, approaches to policy. And if we just focus on the use of medications after a hip fracture, these are data from the UK Clinical Practice Research Data Link. And we can see that when we look at the percentage of patients who initiate bisphosphonate treatment within 1 year after a hip fracture, that has risen, as you can see here, and reached a peak at around 2011. But worryingly for alendronate, you can see there's a drop in the most recent year. We know that in the UK and in many other countries, there's a lot of variation in rates of anti-osteoporosis medication prescription post-fracture. And we can see here in the UK that rates of use of anti-osteoporosis medications is around 10 to 14% prior to a hip fracture. But then in the months post-hip fracture really varies quite markedly from 15 to 34%. And at most in the UK, the CPRD, Clinical Practice Research Data Link studies suggest we've got up to about 45% in total. But that dip in recent years is clearly worrying. We know from work, again, using CPRD that interventions such as policy, for example, the NICE, National Institute for Health and Clinical Excellence, technology appraisal of bisphosphonates in 2005, and also factors such as the genericization of medications can make a difference. And so in this study, looking at rates of treatment of hip fracture patients with bisphosphonates from 1999 to the index period of 2005 and then thereafter, you can see this step change in treatment rates, which is around an absolute difference of 17.2%, a relative increase of 79%, suggesting that interventions at this sort of level may influence rates of treatment. If we look at primary prevention, as we have done in terms of the general use of anti-osteoporosis medication initiation in the UK, we can see that again for women, you can see, and for men there's a rise, but particularly marked in women. But again, this plateau, if not a decrease, in rates of prescription for women since about 2009, and this plateau in men. And this decrease in use of medication is something that's been noted in the European Union. You can see here from estimated sales data for bisphosphonates, again, a tail off in recent years. And in the US, as you can see here from these Medicare data. So we have a picture whereby across both primary prevention and secondary prevention, in recent years, there's been something of a tail off in rates of medication use. And this is clearly hugely concerning in how we deliver best practice for our patients. So what are the reasons for that? Well, there have been with, of course, bisphosphonates and other anti-resorptives concerns about rare side effects, and that's one potential reason. But that at the core of that is how the communication around these side effects has taken place. And as you can see from this chart published in a paper a few years ago, looking at Google search activity, searches for Fosamax, so the brand name for hyaluronic acid initially. And in relation to media events, you can see here that in 2006, there was a massive spike of activity around a US lawsuit against Merck around osteonecrosis of the jaw, another huge spike when there was a major news feature on Fosamax and atypical femoral fractures. And the way in which these rare side effects have been blown out of all proportion in terms sort of relative to the important benefits that these medications give in terms of fracture prevention is, I think, really a lesson to us all as healthcare practitioners in how we communicate with our patients, with our colleagues in primary care and across other care settings, and how we approach the balance between benefit and risks to ensure that our patients do get a sensible appraisal of that balance. And it's quite clear that for those individuals at high fracture risk, the benefit to risk balance is very much in the direction of benefit. And we'll come back to those sorts of issues later on. So in terms of the learning points, I think it is clear that there are major treatment gaps in osteoporosis. We know that some of these reflect the fact that there are just not services there in the first place, that those services that are there may need to expand. There needs to be development across the board. But there are also worrying changes in reimbursement in some countries, for example, the US, reducing DXA services. But there are also these issues around communication of benefit and risk, and bisphosphonates have, of course, been a key part of this. So there's a variety of reasons, but the key point is that these all have to be addressed, and we have to do better to close these gaps and to ensure that our patients do get appropriate assessment and treatment. So continuing that theme then of closing the gap, let's think first about primary prevention and osteoporosis risk assessment. And we've recently undertaken a systematic review of the use of FRAX in osteoporosis risk assessment guidelines globally. And of course, you will all be familiar with FRAX as the global standard fracture risk assessment tool, the most widely used such tool, and allowing you to use a selection of intuitive, easily available clinical risk factors, plus or minus BMD, to compute fracture probability, so integrating fracture risk with survival risk, to give you a probability of a fracture, either a major osteoporotic fracture or a hip fracture over the next 10 years. And in our systematic review, we identified about 120 guidelines that used FRAX, but 38 contained no thresholds. And I won't go into the details of this, but clearly you need to have some kind of threshold or benchmark to enable you to interpret the probability. And I think the important point here is that we know that background fracture rates vary massively between countries. So fracture rates in Denmark, you can see up here, are much higher than those in China. And in terms of how you set a threshold, you need to consider whether you want to tailor that to your country, which seems a very sensible approach, because then you can ensure that people who are at high fracture risk in that country get treated. Or you could take the approach of saying, well, we're just going to have a flat threshold across the world. And the problem with that sort of approach, and that has happened in some countries using the US 20% threshold without reference to their own background populations. And if you use that sort of approach, then, for example, in China, you'll end up not treating anyone because very few people will get above the 20% threshold. So it's important to think about how to tailor intervention thresholds to individual countries. And in the UK, we've taken the approach of an age-dependent threshold, which is equivalent to the probability of fracture conferred by having had a prior fracture. And that stems from the idea that if you've had a fragility fracture, then it's sensible to assess you and treat you for osteoporosis. And this is the approach being adopted in several other areas now. And the UK National Osteoporosis Guideline Group has released guidance updated just at the end of last year. And this essentially at the moment follows a case-finding approach based on clinical risk factors, assessing fracture probability using FRAX. And then, as you can see, linking from the FRAX website to the National Osteoporosis Guideline Group website, allowing you to plot the probability, which happens automatically on this nomogram, and advises either treat or reassurance, or if you haven't had a BMD to start off with, undertaking a BMD measurement to refine the probability. And we'll see later how that works in practice. And the use across the UK of FRAX is huge, and across the world there's vast numbers of hits every year. And certainly within the UK, there's very good linkage to the NOG guidance. And this provides a very workable, easy to use setup, which tells you very simply or guides you as to whether treatment is indicated. And I think, as with any of these sorts of approaches, it's important to take on board that these recommendations, guidelines, but not mandatory. We must retain clinical judgment in our patients, and there will of course be circumstances where you may wish to differ from the guidelines, but they need to be supported by the clinical situation. And so in terms of that sort of approach, very briefly, we've demonstrated in the UK SCOOP study that assessing risk using FRAX, and this is actually with a screening approach in older women, that if you do this through the 7-centre UK study, screening using FRAX, treating appropriately via primary care in those found to be at high risk, you then result in a 28% reduction in hip fractures over 5 years. And this suggests that maybe a screening approach may be sensible in years to come. And I think the important thing is that this approach and the NOG approach in general has been shown to be cost effective. And provides a useful way forward in how we tackle primary prevention. So moving to secondary fracture prevention in our thoughts around closing the treatment gap. Clearly the Capture the Fracture programme is known to you. The fact that you're watching this webinar suggests you've heard of it. And the Capture the Fracture programme, run by the International Osteoporosis Foundation, really so launched in 2012, and it sets out to facilitate the implementation of fracture liaison services to prevent secondary fractures. And it's apparent that through the work of the Capture the Fracture programme and others around it, and the CTF work has really been led by Kasim Javed and Christina Ackerson in the fracture working group. And this work has really demonstrated the great heterogeneity in terms of approaches to secondary prevention and fracture liaison globally. And so the aim was to be the global voice to drive policy and to ensure quality. And critically, and I think critically important for all of you listening, is that this is a real international resource to provide support for FLS implementation. So to help you get started, to help you improve, and to really provide support in going to local providers and payers to implementing and improving these services. So the sorts of benefits that the Capture the Fracture programme can provide is this a way of benchmarking your service, a way of then leveraging that benchmarking for service improvement, support for improvement, the formulation of a best practice framework, a toolkit, these webinars, educational program, mentorship program, and workshops. So it's a pretty comprehensive program that really aims to improve outcomes for our patients in terms of secondary fracture prevention. And I'll just spend a few moments just now considering the benefits of those sorts of programs such as fracture liaison services or orthogeriatrics. And I won't go through this in detail, but just suffice to say that there's evidence from a range of studies, as you can see here, that instituting a fracture liaison service leads to increased medication use post fracture, which is clearly a good thing. And there's some evidence that it reduces fracture risk. And of course, there's caveats with many of these data in terms of it being a very difficult study design to sort out, comparing services with FLS, without, before and after, because there's other things that can come into play there. But the overall body of evidence suggests that there's useful reduction in fracture risk. A group in Oxford, led by Kasim Javed and Cyrus Cooper, Andy Judge and others, has taken a really detailed look at this using some very innovative statistical techniques to control for secular changes and other factors over time. And in the UK South Central region, which for those of you who know the geography, is somewhere around Milton Keynes, Oxford, down to Southampton and the Isle of Wight. And this study looked across a number of hospitals at rates of fracture, so rates of second hip fracture following a first, and rates of mortality following a hip fracture, before and after the implementation of either a fracture liaison nurse post or an orthogeriatrician post. And what they found was that on a background of decreasing mortality, when they meta-analysed the changes from all of the individual centres, for mortality, there was a reduction of around 21% following fracture and liaison nurse implementation, 27% after orthogeriatrician, so very similar reductions. Interestingly, no difference in hip fracture here, and they went into a fair amount of detail trying to ascertain the effect on hip fracture risk independent of mortality. But I think that the key issue here is that, of course, if you live for longer, then you have more time at risk for a second hip fracture. And it may be that it's quite difficult to demonstrate in this way a specific reduction in hip fractures simply because people are living longer, which is clearly a beneficial outcome. So the evidence suggests that secondary fracture prevention may successfully be undertaken through orthogeriatrician posts and fracture liaison services, and that's been demonstrated over a wide range of studies now. And the Capture the Fracture programme from the IOF provides support for service improvement and education, and real international benchmarking and quality standards. And the development of such interventions worldwide, providing uniform effectiveness, i.e. they must reduce second fractures, but importantly tailored to local circumstances, because it's clear that one size will not fit all here, is essential in the long term for us to deliver the best for our patients. So continuing the theme of assessment and treatment, there's some recent evidence around this concept of imminent fracture risk, which I think really usefully and critically informs the timing of interventions. And the key message here is that we should assess and treat promptly after a fracture. And the concept of imminent risk has been bandied around a lot, and there's some confusion about exactly what it means. My interpretation shown here is that what we're talking about is a risk which, after some sort of event, goes up sharply, it remains up for a period of time, but then goes down again. And it's likely that it goes down, as you can see here, to a level that's above where it started from. And of course, risk goes up with age, so it's never going to go down to exactly where it was before. But that contrasts with somebody who's just at high risk of fracture. And somebody who's at high risk of fracture, for example, they've got low bone mineral density, they've got a strong family history of fracture, they're going to be at high risk of fracture today, at high risk of fracture tomorrow, and at high risk of fracture in 10 years. So something like a low BMD test, a low BMD from a DEXA, doesn't increase your risk in the short term, well, not unless the DEXA technician is particularly clumsy when pulling off the table. But in the long run, this just tells you that you're at high risk. And so we need to differentiate from high risk to high imminent risk. And this is where we look at these data from the Icelandic Reykjavik cohort, which suggests that if you look at the incidence of major osteoporotic fracture after a first, this is shown here on the y-axis, we can see that the risk is very high in the first couple of years, but goes down and then gradually just increases again in line with age. And if you look at the relative risk relative to the risk of a first fracture in the whole population, this is around 2.7 in the year 1 and 1.4 at year 10. So the key message here is that risk of a second fracture after a first is highest in the first couple of years and then wanes thereafter. And this is a true transient imminent risk effect. And we can see here further in this work that we undertook with that Icelandic cohort that the effect seems to be greatest at older ages. And so the key learning points here pretty obvious. Based on these data, the occurrence of fracture increases the risk of a subsequent fracture. The risk is particularly increased over the first 1 to 2 years post-fracture, and assessment and treatment of osteoporosis to reduce fracture risk should be undertaken urgently following an index fracture event. And that clearly supports the concept of fracture liaison services and that we should not be waiting around to start treatment. If it's indicated, we should be assessing and treating as a matter of urgency. So that gives you a very science-based background and context in which to talk about the nitty-gritty of particular approaches to treatment. And I thought what I wouldn't do is simply go through all of the treatments and tell you their pros and cons and indications and side effects and so forth, because that would make for a very tedious 20 minutes as we go through the second half of the seminar. But I thought what I would do is just share with you some case histories which really illustrate some particular principles with a very focused, clinically pragmatic approach. So we know that there's a number of licensed anti-osteoporosis medications, mainly anti-resorptives, across bisphosphonates, denosumab, then Serm, Raloxyfan, anabolics. We have teriparatide, and of course in the US now we have abaloparatide, and we'll come back to the newer treatments towards the end. But I thought let's just look at a case of Mrs. FNF, who's an 80-year-old female. So she fell at home, unable to get up, was found to have a left fractured femoral neck when she got to hospital. And she was actually in pretty good preoperative state, independent, healthy, other than her fractured femur. She was admitted, operated, and is back home. Now, of course, before she goes back home, you want to assess and treat her for osteoporosis. And most guidance would tend to suggest treatment on the basis of the fracture without need for DXA, although DXA is, where it's available, extremely helpful in terms of providing further information, not just to help support immediate treatment, but to support longer-term assessment, response to therapy, and help with adherence and so forth. So as we look at specific approaches to treatment, I've broken this down into 3 hypothetical scenarios. One is in which Mrs. FNF has normal renal function and no gastrointestinal problems, one in which she has renal impairment, and one in which she has normal renal function but severe upper GI reflux. So if we look at the sort of base case first, with normal renal function, no GI problems, well, she's independent, she's able to swallow, she's mobile. There's probably no reason why she couldn't try an oral bisphosphonate such as alendronic acid, taken once weekly on an empty stomach with a big glass of water, and then remaining upright for 40 minutes or so afterwards. Clearly, there's issues that we need to consider here, and it's vitally important that she is vitamin D and calcium replete, and that should be assessed. There are good calculators, so IOF advise on this, and some from other national societies, calcium calculators. But it's these issues must be addressed, and importantly, anti-osteoporosis medications are generally licensed on the basis of repletion in calcium vitamin D, and we'll come back to the details of that. We need to think about where she's going home to, and it seems that she's in pretty good health state and is going home to her own home, and has some relatives around, and she'll be independent But it might be that she's more debilitated and ends up needing residential care, in which case she's probably at high risk of vitamin D deficiency, poor mobility, etc. And if her mobility is poor, then of course falls is a major risk. If there's cognitive impairment, she may well not be able to comply with the weekly alendronic acid, and therefore compliance and adherence may be poor. And the renal and GI considerations are clearly key to these scenarios. So with these in mind, it might be that if she deviates from this sort of base case, then a parenteral therapy such as denosumab subcutaneously or an intravenous bisphosphonate zoledronic acid might well be a more sensible option to make sure that she's got treatment before she leaves hospital, as long as we're sure that she's vitamin D and calcium replete. So I won't labour the point about bisphosphonates, but there's good evidence that they lead to reduction in vertebral fracture and clinical fractures, evidence for some on hip fracture. And these bind to bone, and they're taken up by osteoclasts and inactivate osteoclasts by a variety of means. And this leads to a slowing of bone turnover and the opportunity for the bone, the infilling and consolidation of existing bone structure, but not critically the anabolic addition of new bone structure. So if we think about the second scenario, if she's got renal impairment, well, most anti-osteoporosis medications are contraindicated at this sort of level of renal function. Denosumab is okay in terms of safety from in terms of renal function, but of course there is an increased risk of symptomatic hypocalcemia with denosumab as renal function declines. And of course, the other thing to think about is that if somebody has really poor renal function, is down at the CKD4/5 level or end-stage renal failure, then it may not be straight osteoporosis, which is the bone issue. It may be that there's renal bone disease in there as well. And if somebody's got reduced bone turnover, then giving denosumab may well not help. And so at the severe end of renal function, then it's definitely worth involving specialists in the decisions around treatment. But just to stress the point, vitamin D and calcium repletion is vitally important ahead of denosumab treatment to avoid the risk, avoid a major risk of symptomatic hypocalcemia. It's also important to consider who will give subsequent doses. In the UK, we've moved from the use of denosumab purely in secondary care to initiation in secondary and then continuation in primary. And then now in many areas, it's wholly a primary care intervention. But it's important to work this out because there's some evidence of increased bone loss. You certainly go back towards where you were. Some evidence perhaps you go back even more than you started off from, as it were, with case reports of multiple vertebral fractures after denosumab cessation. So it's important to continue the denosumab, and in the situation of an elderly person who's had a hip fracture, you may well just continue that lifelong, because the risks are going to outweigh the benefits are going to outweigh the risks. But a long-term plan is important. And of course, one wants to consider the risk of falls as well. And just to give the details on denosumab, you'll be familiar with this, but denosumab is this equivalent of OPG, which blocks the interaction between osteoblasts and osteoclasts through the rank ligand system, and this leads to an osteoclast poor bone with slowed bone turnover. So just coming on to the last scenario, where we have normal renal function but severe upper GI reflux. Well, again, oral bisphosphonates will be contraindicated here because of the risk of the medication lodging in the esophagus and causing ulceration. Although there are potentially depending on how bad the reflux is, and swallowing and so forth, there may be a place for newer forms of liquid or buffered bisphosphonates, which may be helpful. But it may well be that the subcutaneous denosumab or IV zoledronic acid are appropriate here. And zoledronic acid, of course, has been specifically investigated post-hip fracture in the Horizon study, and of course reduces the risks of future fracture, as does denosumab. So these would both be options in this sort of situation. And again, with the provisos around calcium vitamin D repletion, how you would give the therapy and whether that's in hospital. And often in these sorts of situations, there's sufficient time as an inpatient to ensure calcium vitamin D repletion and then a dose of treatment before going off into the community. And how exactly that happens, of course, depends on the local setup and the local services. But the absolute key thing is that the patient gets the treatment. And so if that has to be in secondary care, great. If it has to be in primary care, great. But it has to happen, and that's the key point. So just a few thoughts on the approach to calcium and vitamin D repletion. As I say, we need to avoid the risk of symptomatic hypocalcemia with zoledronic acid or denosumab. But we should avoid high doses, high bolus doses of vitamin D if at all possible. There's evidence from Australia and a more recent study in Europe that giving doses of cholecalciferol, so 500,000 units, or even 60,000 units, is associated with greater risk of falls. It's unclear why that is, but the association is there. And generally, the move in the field is towards daily oral dosing as the optimal method, with a higher dose initially. Somewhere around 3,200 units is a convenient dose, and then 800 a day maintenance. You might give a higher dose for a couple of months to replenish the stocks before moving to maintenance. But it may be that there's just times when you need to get the doses up more quickly, and the logistics mean that a higher bolus dose is needed. And in that situation, it's probably better to give a higher dose if it means that you can get the definitive treatment, such as zoledronic acid or denosumab, into the system before a patient goes home, rather than risking them getting no treatment at all. And generally, oral is better than parenteral. So intramuscular vitamin D tends to be poorly and erratically absorbed. So oral treatment is definitely better if it's taken. So in our penultimate case, I'll just think about the approach to postmenopausal osteoporosis in a lady who, by some coincidence, is Mrs. PMO. This is a 60-year-old lady who has attended with a concern about low bone density, has a family history of a mother fractured a hip, and has gone through the menopause and is concerned about bone health. So putting the various clinical risk factors into FRAX, and you can see here the fracture risk assessment tool as set out on the web. We can see we put in factors such as age, sex, weight, height, previous fracture, parent fractured hip, current smoking, use of glucocorticoids, rheumatoid arthritis, a variety of secondary osteoporosis factors which are listed down below on the FRAX website, excessive use of alcohol, and then you can put in femoral neck BMD if that's available. And it's important to input the make of the DXA scanner and the absolute BMD measurement, because rather than the local T-score, because it's important that the right reference range is used for the correct FRAX calculation. And this gives her a major osteoporotic fracture of 19% and a hip fracture probability of 3.6%. You can see here, if you happen to have a trabecular bone score value, then you can adjust the FRAX probability for that. And that tends to be at most use if your patient is around the intervention threshold on NOG. So in the UK site, we can link directly with our National Osteoporosis Guideline group, and other countries are starting to address this as a way forward. And you can see here that Our Lady Mrs. PMO is above the intervention threshold here for both major osteoporotic fracture and hip fracture. So what do we do? Well, she's healthy, she's not frail, she's able to swallow, she's got good renal function, so probably oral alendronic acid is a good first line treatment. It might be that local policy suggests other oral bisphosphonates. And of course, she needs to be calcium vitamin D replete. And in most of these situations, then calcium vitamin D supplementation may well be helpful. But if that's not tolerated, then just a pure vitamin D supplement would be sensible if there's enough calcium in the diet, for example. And it's important to stress that we now have licensed pure vitamin D supplements available from several companies, and that we should be using licensed preparations rather than food supplements, which is what most over-the-counter vitamin D supplements are, which are not regulated in the same way as licensed preparations. If Mrs. PMO tended to had low spinal BMD, wasn't particularly bad at the hips, and was several years postmenopausal, we might think of Raloxyfan, a selective estrogen receptor modulator, as an alternative. And this is it seems generally well tolerated and is particularly useful in that sort of setting, particularly if women are not keen on bisphosphonates. Ultimately, if none of the oral therapies worked or were tolerated, then zoledronic acid or denosumab might well be alternatives. So finally, in our case histories, thinking about the unfortunate Mr. VF, who's a 72-year-old male who presents with a severe vertebral fracture. And that's in the context of an increase in kyphosis, previous treatment with alendronate for 5 years, and then he had a break, well, it turns out literally, from the treatment, and a radiograph reveals multiple vertebral fractures with low femoral neck BMD at -3.6 on DXA. And in this sort of situation, one would certainly think about an anabolic agent. Exactly how this is used varies enormously from place to place. For example, in the UK, NICE, based on health economic grounds in women, have placed it very much at those women who are older, have had prior fractures, low BMD, failed other treatments. But availability varies a lot around Europe and the US, for example. But an anabolic agent such as teriparatide, which has particularly good effects on BMD and vertebral fractures, so BMD at the spine particularly, or abaloparatide, which is now licensed in the US, may well be an option. And these so the approach for teriparatide is a daily subcutaneous injection, 18 months to 2 years. And importantly, one wants to follow this up with an anti-resorptive to consolidate the gains in bone mineral density. So I'll just in the last few minutes just touch on a couple of new treatments and some issues around rare side effects. And I won't spend a lot of time on this, but just to say that we're in exciting times currently, and there are new treatments on the horizon. We've not had any for a few years now. But with abaloparatide, which is an analog of PTH-RP, so it's similar to teriparatide, but showing efficacy for vertebral fractures and for clinical fractures in the active and active extend trials, licensed in the US and hopefully will be in Europe in the next in the coming months. So we look forward to that being available. Secondly, on the Wnt signaling pathway targeting sclerostin, and sclerostin a key part of the Wnt pathway that underlies several either low or high bone mass conditions, is anti-sclerostin antibodies, so romosozumab, shown in several studies to improve BMD and reduce fracture risk, both vertebral fractures and clinical fractures. And this in the FRAME study in postmenopausal women who are osteoporotic, but not focused on previous fractures, effective versus placebo. And then in the ARCH study, which was in higher risk patients who'd had a prior fracture and osteoporotic, again, efficacy for vertebral and clinical fractures, but just this issue of an excess of serious cardiovascular events, although you can see the absolute proportions are very low in the intervention group, which is being looked at in the licensing process. But it's exciting that we've got those two new treatments, hopefully both coming online. So just coming back to this issue of rare side effects of anti-resorptives, I won't spend a lot of time on this, but osteonecrosis of the jaw and atypical femoral fractures are rare events, and I think it's important to recognise that these are rare events. You might not think that from the sorts of press coverage that they get and the things that that patients read online, but these are rare events, and they need to be, when we're talking about events that happen of around, in the order of 1 to 90 per 100,000 patient years, then we need to think about this in the context of a 20% risk of major osteoporotic fracture, for example, in the next 10 years, and consider the benefits of being on treatment and reducing fractures, which cause enormous morbidity and reduce survival, compared with a tiny risk of these rare events. That said, we need to certainly consider them and discuss them with patients, but that discussion needs to be a sensible appraisal of risk benefit, and to avoid scaring patients off using what are beneficial treatments for the vast majority of individuals. There's international guidance on these issues from ASBMR and from the IOF, and importantly, the work from Bo Abrahamson, published in the BMJ a couple of years ago, has demonstrated that, as with some other studies, that the epidemiology of subtrochanteric femoral shaft fractures is similar to that of hip fracture, although at lower level. And even in this Danish study, use of alendronate up to 15 years, the number of hip fractures saved through being on treatment exceeded any subtrochanteric fractures which were there. And of course, you can't impute causation, and it would be a minority even of these subtrochanteric fractures which are atypical. And these are really reassuring real-world data suggesting that even at 10, 15 years, the benefits of being on oral alendronate outweigh the risks. And so the approach to long-term treatment is outlined for our UK policy in the National Osteoporosis Guideline Group guidance. And I think I would put this in the context of that treatment gap and saying that not enough people are treated generally. And therefore, my own view on this is that we should be focused on treating people rather than not treating people. But also mindful of these issues around rare side effects, and whether, given that bisphosphonates are act for a long period of time in bones, treatment is needed continuously. And so the approach for, so 5 years for oral bisphosphonates, one might think about maybe a shorter period for perhaps shorter acting bisphosphonates such as risedronate, or 3 years for zoledronic acid. If somebody's not had a fracture, then you may reappraise risk after 3 to 5 years. And then if somebody's found to be at low risk of fracture, then you may wish to have a year or two off treatment. But if somebody's at high risk of fracture, then you would certainly want to think about continuing treatment. And in my experience, if somebody's at high risk of fracture at the start of treatment, it's unusual that treatment reduces their risk of fracture to a level that I'd be comfortable to have much of a period of treatment, except perhaps with zoledronic acid, where it is so long acting that, you know, and it's a year between treatments anyway, that you might go for 2 years and then and think about starting again. And there, factors such as bone turnover markers can be helpful in guiding when to start again. But if somebody, you know, in the older population, those with the previous hip fracture or vertebral fractures on glucocorticoid therapy, have a high frax probability or a low BMD, then you'd certainly be more towards continuing treatment than having a break in treatment. And I'd certainly, the emphasis, I think, should be on making sure that individuals are treated appropriately in the first place, and that people do not come off treatment unnecessarily. So, as I bring this to a close, I'll just conclude that clearly osteoporotic fractures are common. There's a huge burden of disease globally, and it's absolutely essential to undertake both primary and secondary prevention. The Capture the Fracture programme provides support for the latter, and this is a really central venture globally to benchmark quality and provide a service to leverage service improvement locally. We do have the luxury of a wide range of effective medications available now, and the onus is really on us as a community to take the steps needed at the local level, at the national level, at the international level, to ensure that those at high fracture risk are targeted for assessment and treatment, and make sure that nobody who should be treated goes untreated. I'll just finish with a quick mention of a couple of UK meetings in the summer, Molecular Pharmacology in Oxford, and then our own Bone Research Society hosted by Southampton in the historic city of Winchester at the end of June. So if you fancy a trip to the UK, to a beautiful city in Oxford or Winchester, then do come along. Thank you very much to the sponsors of the Capture the Fracture programme, UCB and Amgen. And then I'll finish there and look forward to any discussion in the remaining minutes. Thank you.
Thank you very much, Professor Howry, for your fantastic presentation, underlining the treatment gap, covering the various pharmacological interventions available for osteoporotic fractures. We also appreciate that you mention and emphasize that implementation of fracture liaison services really focuses on the higher fracture risk patients, preventing the next fracture, improving treatment initiation, and compliance in the long run. Now, we would like to dive into the questions and answer session, as we have received a number of questions during the presentation. Now, I would like to start with question 1. What are some of the reasons behind this notorious 80% gap with many patients never receiving treatment? And what are your suggestions to improve on this?
Yeah, I think that this is a really important issue, and I think, as I sort of alluded during the talk, that there are several issues around this. And I think, firstly, just that, you know, as things have developed, we're still not historically treating as many people as we should do, and we don't always have the service provision there to facilitate optimal treatment. And that's where programs such as Capture the Fracture are essential at the international level, and how national societies and leaders nationally can really push the agenda to ensure that fracture liaison services are available, but also to address the issues around primary prevention and make sure that we have mechanisms whereby high fracture risk individuals can be detected. And as as things are more and more computerized and automated, there's ways in which those things might be implemented, for example, in primary care computing systems. But I think, as well as those sorts of issues, that there is a clear problem with the way that these rare side effects of long-term anti-resorptive therapy have been communicated to patients, and also from those of us who are specialists to more general, the field more generally, and to those in primary care. And the net result of that is that often patients and primary care physicians are more concerned about the side effects than they are appreciative of the benefits of being on treatment. And that's something that we as a field should think really carefully about and really try to change how we address these issues, to combat negative messages, to get a balanced, sensible view of the benefits versus risks out there. And it's something that is clearly part of the current international collaboration between societies such as ASBMR and IOF in addressing this crisis of osteoporosis treatment, particularly, for example, in the US, where reimbursement policy is changing, but issues across the world. And we need this sort of venture to address these issues, as well as key ventures such as Capture the Fracture, to improve services for those at highest risk.
Thank you, Professor Harvey, for your answer. Now, moving on to question 2. What is your take on SERM drugs such as Raloxyfan? It may not be a very powerful drug, but it could be an option, for instance, in patients that are at risk for certain adverse drug reactions. Is this a good alternative for some patients?
Yeah, absolutely. And I think it tends to be a reasonably niche sort of area, but and particularly because the studies show good benefit for reduction of vertebral fractures, but not much evidence for reduction in non-vertebral fractures, particularly not for hip. And so in a very high-risk patient, you'd probably think about something else. But in a has to be postmenopausal female, and particularly where there's a reduction in spinal BMD, or the patient is at enough risk to treat but not particularly high risk, then Raloxyfan can be a very well tolerated treatment, which is often perceived by patients as being a bit more gentle than the bisphosphonates, and we certainly find in that context it can be effective and well tolerated. Of course, one needs to bear in mind the potential increased risk of deep vein thrombosis, but also the benefit in terms of reduction of breast cancer risk. So in somebody who's got a family history of that disease, it can also be a helpful intervention.
Thank you, Professor. Unfortunately, we only have time for 1 or 2 more questions. So let's give the final question. Is it clear for fracture liaison services how long the patients will need to be treated with drugs for osteoporosis? Guidelines say 3 to 5 years, but not knowing this might reduce compliance in many patients. And what would you recommend on improving medication compliance?
Yeah, I think that's an absolutely critical issue, and it's all very well us prescribing things, but if patients don't take them, then there's not a lot of point. And we know that across the board in treatments for prevention of conditions, just in whatever system, then medication use, medication adherence tends to be quite low, and that's the same in osteoporosis as it is in other areas. But in terms of how one addresses that, clearly I think the overall message is important in terms of we should be treating rather than not treating, and that's a nuance that can get a bit lost in terms of how we talk about treatment holidays, for example, which is a term that is probably, it captures less well how we really want to approach this. But in terms of the practicalities of encouraging adherence, various things have been tried, and I think the overall message is that following patients up, talking to patients through either physician or specialist nurse or practitioner, probably is the most successful. Other ventures have tried looking at bone turnover markers and looking at changes in BMD, for example. But my understanding is that probably the most important part of all of that is the nurse contact, the nurse contact or the doctor contact, and somebody taking an interest in medications, and also how you approach the exact questions used and so forth. And there's ways to elicit adherence information better than other sorts of questions. But putting that together, there's a lot of issues around the practicalities, and I think really just the messages that the patients get up front, that they need to understand these are long-term treatments. It might be that there's a period off treatment at some point, but they should view it as a long-term treatment. And somebody who's had a hip fracture, it's highly unlikely that they're going to end up with a period off treatment, particularly as they're likely to be frail and they're elderly. And we should be thinking in that direction, and doing all we can to encourage adherence.
Thank you, Professor Harvey. I believe that patient education and communication is key to this. Now, unfortunately, we have come to the end of this webinar, and I just want to take the last minute or so to thank all the attendees. Thank you very much for your participation, and we really hope that you enjoyed this session. Now, if you have any questions, please feel free to send it over through email, and we will post recordings of this webinar on the Capture the Fracture website, which is capturethefracture.org/webinars. Now, after this webinar, you'll be asked to fill in a survey. Now, as we are currently deciding on the topics for this year, we'd appreciate your input very much. And on that note, I would like to wish everyone a good day. Professor Harvey, thank you again for your fantastic presentation.
Well, thank you, and thank you everyone for listening.
Thank you. Goodbye.